So we'll just finish up the first part of the talk, and we'll move to our other part. And I wanted to make sure we talked about this. So this is work. So in the center is work as we actually do it. When you're on the floor, in your pharmacy, or working at your desk, is work as you actually perform the tasks. And if we start at the bottom, there's work as observed, is how you work when other people are observing you, and how those observers look at you and try and record or document what you're doing. Work as documented is after you've done your work. In healthcare, a lot of times you have to write about it or do things like that. Work as claimed is when you're talking to people explaining your work. Work as imagined is how other people imagine you to do your work. So people maybe in leadership positions and other positions, how they sort of think about what you should be doing or how you're actually doing it, which may not be actually how you actually do it. Work is abstracted for those who have to code, if you're doing ROI calculations or other calculations of intensity, how you actually code or force the work into these constructs, into these code constructs. And work is simulated again, is how you actually sort of pretend to do your work, or if you're training, how you actually do that. And the difference between work as done, and work as imagined is important. So, because we focus a lot of our efforts of improving healthcare on how work is imagined. So lots of people in managerial positions or oversight positions imagine you to do your work in such a way. And that is the basis of training, of education, of control, but it may not be exactly how the work is actually performed. And that's where the systems that are set up as imagined can break down and cause problems. So work as done is what truly occurs and what people actually do. And that's the important part, and that should form the basis of what we use for education, for training, for process improvement, for system improvement. To finish up, for humans, we have other limitations. We're easily distractible, and the list of things I did that Chris talked about earlier proves I'm easily distractible. People are tired. People sometimes just don't know. They have a knowledge deficit, but organizational culture plays a big role in how people perform. So if you have a very positive and proactive safety culture, workplace culture, it's far easier to get things done. It's far easier to do things safely than if you have a very poor safety culture. And humans, by and large, have economical laziness. So that's not laziness to cause harm or malfeasance or anything like that. It is just lazy because we find efficient ways of doing things. If there's a lower effort way to do something, we will probably pick that. And sometimes that leads to problems. So we're not designed to operate at 100% of our specifications, and we behave in predictable ways, both good and bad, and have predictable limitations. And that makes the design of systems and processes and devices so important. So we've talked a bit about a number of different things about problems with humans, and now I'm just going to sort of move on to the next step and sort of put things together and sort of go through a few exercises that help us with that. So Canadians are often thought of as being very polite and understated, and that's entirely accurate. So coming up in this part, we'll finish off our exercise on the Breezhaler device and talk a lot about what we do about errors and how we design things and how we at ISMP Canada try to come up with recommendations. So Steve Jobs said, design is not what it looks like and feels like, which is important, but design is also how it works. So how the end user in particular is going to use a product. So how the work as done sort of fits into how the product is used. So we'll go through our medication device exercise. Does anybody have one of those devices, those Breezhaler devices? Where do they end up? Can you toss it in my direction? Or here, this one's closer toss. Thank you. So the way this works, and the video would show you, but I'll do it for you. If you haven't, so there's a separate set of capsules that you have to break open. You put it in this device. Okay? You close the top. And these orange buttons at the side squeeze it. They puncture that capsule, which releases a powder medication. And then you breathe out, and you suck all the medication up in there, and you're supposed to count to about 5 or something like that. And then if you don't feel you got it, or if you feel it still rattles, you should do that again. And then you take this off, empty it out, and put it back for the next time. So that's how it works. So what we do at ISMP Canada is we often do what's called a failure mode effects analysis, or FMEA, and we teach a lot of workshops on this. And we're going to put you through one based on this Breezhaler device. So the failure mode part is how things can go wrong. So how people can screw up, essentially. How people can misuse a device, or what sort of mistakes can happen. And the effects analysis is what are the effects if people do screw up, if that mistake does happen, if that wrong pattern of usage does occur. And it's prospective typically. So when you're introducing a new process, we're introducing a process or a different type of label, we'll do one of these. So we'll look at, well, how many ways or how many mistakes can we make with this label? And if we do make a mistake with this label, what's going to be the effect? So if we pick ciprofloxacin instead of clarithromycin, okay, that's the failure mode. We've picked the wrong drug. So what might the effect be? Well, the effect might be, well, someone gets exposed to something they're allergic to, or the antibiotic doesn't cover the type of bug we're trying to get with it. So how many ways can people go wrong, and what happens when they do? So does anyone want to take a stab at how you can mess up with that Breezhaler device? So we'll pick you. Sorry? Okay, swallow the capsule, that's excellent. So that's the failure mode. So people open the capsule and it looks like every other capsule you should swallow, so they swallow it. So the failure mode is you swallow the capsule. Now the effect part is, okay, yeah, there may be more than one effect. One is the effect, well, you don't get the lung delivery of the medication that you're supposed to, and your lungs don't feel as happy as they would. And you actually swallow the capsule and you get some sort of systemic effect from whatever drug is in there. So there can be more than one effect from a single failure mode. Does anybody have any other thoughts on how people can mess up? They blow into the device, so they go in the wrong direction. So that's the failure mode, and the effect might be, sure, they can lose the dose, or they don't actually get the drug in the lung because they're actually blowing out. Okay? Right, you can put pretty much any capsule or any candy that fits in there, you can put that in. So that's the failure mode, and the effect is, yes, you got it. Anybody? Yes. So that was one of the first things reported to us when they introduced this in the market, is people put the capsule in the top. And they went, ooh. So that is still lung delivery of the medication, I suppose.
How much pressure is required to squeeze that?
Yes. Yeah, some people, like the elderly with quite arthritic hands, may not be able to press that. So that's a failure. You can't puncture the capsule. And then the effect might be, I don't get any medication, or I just stop using it because it's too physically hard to use. So we came up with, when we did this, we came up with this, but some more, but these are the sort of the highlighted ones. No capsule in chamber, you got that. Capsule in tube, aspiration, by mouth, not crushed. So you have to dump stuff out, right, after you've done. There's sort of a plastic resin type capsule coating, and that can plug up the ventilation tube, so you keep doing this, but you don't actually get medication. It requires sufficient force, and you can put actually anything in that capsule as well. So that's a sort of fly-by-night failure mode and effect analysis, so how things can go wrong and what might the effects be when that goes wrong. And we thought this was important that people know about because a couple of years ago, a whole number of different type of inhalation devices came on the market in Canada, and we were getting reports all over about things not working right, things going wrong. So we wrote a bulletin on this. This is April of 2016, and we made a nice poster of the 4 different new ones coming on. So I don't know how many are available here in New Zealand, but we have these 4 new ones. So design and failure modes, or failure modes and effects. So design is very important, and this is relatively a complicated multi-step device to get drugs in. If you remember the meter dose inhaler, you just sort of shake and blow in. It's much less complicated. So this is, maybe poor design. So this is a picture of in southern Florida. And these are all intersections in southern Florida, actually. So there's 22 lights, each containing 3 lamps, so that's 66 different pieces of information available to someone that stopped at this intersection. So a failure mode of this design might be, I'm paying attention to the wrong traffic light. And the effect might be, well, I go at the wrong time and cause a crash or get injured, or I don't go because I'm paralyzed by all this information. So this is, so the failure mode here might be, a violation of personal space. And, the effect might be, significant awkwardness or whatever. So, yeah, so this is poor design, or design in a way that, doesn't really work. So I think the idea here is correct. It's a good idea, but the execution of the idea is not really all that good. So this is, the failure mode is, there's things exposed, and for, the same reason. So this is, the failure mode is there's conflicting pieces of information, all right? And the effect might be either, you turn at the wrong time, you turn on to oncoming traffic, or you don't do anything at all, you just stand there. So the bottom small says the bridge is out ahead. So the failure mode is it's the wrong information is highlighted. The effect is you end up in a ditch. So this is from San Francisco, and there's no stopping on Wednesdays and Thursdays, and it all says temporary on it, and it says Monday only, and it says midnight, but then it says 4:30 to 1, and so the failure mode is there's just too much conflicting, complicated, restricted information, and the effect might be either a traffic ticket or you drive around the block again looking for a different spot. So this is from my 6-year-old school. So sort of these design problems. So, the failure mode might be you're off the side and you don't see the numbers, or the tape falls off, and your effect is you're late for class or whatnot. So this is particularly germane when you kind of change systems or change the way you do things sort of midstream. So you often don't think of what the failure mode should be, or how the change itself, or how the jerry-rig or the temporary fix becomes permanent and then leads to problems. This is also, of course, a problem. So what's the failure mode here? So, Yeah, and this is here really to remind us all that failure modes can occur in any direction, right? So the failure mode, if you're making bacon and eggs, is you use the fly and insect killer, right? And then you get some, GI something, or you have to phone the toxicologist because they're look-alike, sound alike. But there's also failure modes in the other direction, right? So if you're trying to kill flies, you pick the canola oil and you end up with greasy flies all over the place. So failure modes, it's important to realize, can work in many, many different directions. And the effects are, can spread out, can be quite different. And this is just not good. And this last one here is just to remind us what Steve Jobs said earlier, is that you have to take into account what the end user sees or how the end user does it. So how the work actually is imagined, or how the work is actually done. So this is what actually happens to pencils. They get sharpened and your messages change significantly. So we need to design systems that understand and accommodate performance limitations. So we talk about high reliability organizations like aviation, nuclear power, chemical power. Healthcare is changing, thankfully. There still are some of these elements in healthcare. Back probably when I started, we still did morbidity and mortality rounds when I was in medical school, and those were quite, honestly, pretty vicious. Healthcare, sometimes, but again, it's changing. Errors are the result of human failures. Humans are supposed to be that solid block of Swiss cheese and perform flawlessly. We're supposed to be perfect. And we've often used, we don't anymore as much, retraining, punishment, loss of privileges or firings or things like that, just to root out bad apples. However, high reliability organizations, they start with the thought that, yeah, humans work in this system, so things can go wrong. We understand that things can go wrong, so we have to work at fixing the systems to allow that to absorb the problems. We don't expect humans to perform perfectly. We practice mistakes. Okay? In healthcare, we don't practice a lot of mistakes. There are some simulation labs that do practice mistakes, but nowhere to the degree that pilots would. I have nieces in the nuclear power industry, and they're operators, and they have simulations where things go terrible. And they're expected to learn from that because the understanding is they practice making mistakes. They understand that mistakes happen. Healthcare, we don't practice mistakes. We learn, we learn by doing, we learn by simulation, and we practice terrible things like running codes or acute coronary life or acute care life support. We've practiced traumas and things like that. But we don't practice the run-of-the-mill thing all of a sudden going terrible. So it's an interesting difference. And consequently, they design systems in a proactive way. They want to try and understand this is how humans behave and what they do. So let's design the system to catch those errors, to prevent those errors, to prevent things like that from happening. And that brings us to more human factors engineering or clinical engineering or ergonomics in some places. So this is the design of systems, tools, processes that take into account how humans actually work. And they work to make the environment function in a way that seems natural to people. So you're not, feeling stressed or feeling pressured or feeling encumbered. The things that you need to do seem more natural to you or much better for you. They look at the relationship of people to the machine or product, so the thing you're working, process or procedure. They look at things towards an organization, and they look at other people. And again, they sometimes go by different names depending on where you are. So how do they make things safer? Well, we use them a lot when a patient safety incident occurs. We perform an analysis. I'll teach you a little bit about that, or I'll show you how that works afternoon. Identify the contributing factors. We develop and design the strategies, and we use human factors principles. And human factors principles are basically what I've talked about. Humans have performance issues. We kind of do things in predictable ways, and we have predictable behaviors that sometimes cause errors. And we require interventions to prevent these types of errors. And so we try and design the potential for these errors out of the process. And we go upstream as far as we can in the process. So, and what I mean by that is if you influence pharmacy-patient interaction, that's great. You've helped 2 people. If you influence a pharmacist somehow, then you've helped all the people that the pharmacist comes in contact with. If you influence a whole pharmacy chain or a pharmacy organization, you've influenced many more people. Or if you can influence a whole healthcare system, you've influenced, how many thousands of people. So there's benefit from all around there, but there's, more benefit maybe if you go higher up the chain as possible. So when you think of recommendations or interventions or strategies, certain types are more likely to change behavior than others. And they last longer than others. And these interventions, if you sort of separate them out or classify them, you can group them in a hierarchy. And we call that the hierarchy of intervention effectiveness. And I'll go through a couple examples. They're high, medium, low leverage interventions, system-oriented versus person-oriented. And I'll talk about the trade-off between the feasibility of some recommendations and the effectiveness. So this is one design of the hierarchy of intervention effectiveness. And if you Google that, you'll come up with a number of different ones. Some people call them hazard control, hierarchy of hazard control. So the upper step is a forcing function. I'll explain these in the next couple of slides. So it forces you to do something or prevents you from doing something, forcing function or constraint. Automation, computerization is helpful. Simplification and standardization. So making things simpler, making the process simpler, or standardizing things so that everybody knows what's happening or the same things occur at the same time. So all these 3 things work on the system. The bottom 3, reminders, checklists, double checks, rules and policies, education and training, they work on the person. Okay? It's incumbent upon the person to be diligent, be attentive to that, to work. You still have to do those, but they're not quite as effective, they're not quite as long-lasting as the system, the big, harder system changes. Another way of looking at it is this design, the hierarchy of effectiveness. The same elements are there, high leverage, forcing functions and constraints, automation, simplification, reminders, all the way down to education. The higher up you go, it's the most effective, but it's often the least feasible. So in Canada 15 years ago, we really struggled with hydromorphone. We were severely injuring and killing a number of people. So the most effective way to not make a mistake with hydromorphone would be to just stop making it, stop using it. Okay? But it's often the least feasible because hydromorphone is actually a very useful drug. I do a lot of palliative care with it. And no one would ever accept that we took away this drug. It would just be too unfeasible to really, really use. So even though it's most effective, it might be least feasible. And this certainly goes for high resource things like computerized systems or robust health IT systems that it's could be very effective, but often it's very cost prohibitive. It involves a lot of change management. So some real life examples. So what's the forcing function here? Okay, anybody else? Can I turn this on like this? Right, you have to shut the door. So you have to do the safety thing of shutting the door before you actually turn it on. So it forces you to shut the door before you heat up your waffle or whatever you're eating. So forcing function here. Or why can't my 3-year-old put it in gear? Yes, so I have to put on the brake pedal before I put it in gear. So that's the forcing function. So you have to anchor the car or vehicle before you do. And you guys drive on the wrong side of the road, so it's very complicated for me to do that. So that's the forcing function. It forces you to do one thing or act in a certain way or do a certain thing before it even allows you to do that. Forcing functions in healthcare, so connectors are different sizes. So in Canada, you can't plug your oxygen tubing into the medical gas or into other gases that we provide because the tubing's different. So you can't inadvertently give someone nitrous oxide instead of the oxygen. We had a lot of problems in North America with enteral things like feeding or crushed medications being delivered intravenously. So we're transitioning, and it's pretty widespread now, for the enteral connectors. So the enteral connectors on enteral devices cannot fit into the lower locks on your IV, so you can't give feeds intravenously. Okay? So it just prevents you, it forces you not to do it, because you can't unless you significantly sort of modify or sabotage the system. Automation, computerization, automated dispensing carts, very useful in healthcare. A number of places in Canada and most hospitals in the US now have barcoding for patient identification. So you barcode the patient and your dispensing cabinet automatically opens up that drawer for that patient. So it really reduces the wrong patient error. But you still have to make sure that your bracelet is appropriately attached to the correct person. Simplification and standardization. Simplification and standardization in healthcare, things like pre-printed orders or care paths or things like that. This is how the processes get standardized, so there's not a lot of variance anymore, or less variance. Simplification and standardization in code carts. This is a little bit older now, 2003. And this was a series of mock codes and time to prepare and administer a certain number of drugs. So the original one on your left, and the newer simplified one, standardized one on the right, which has the medications in the anticipated sequence during a code, and all the labels are upright, they're all facing you, they're all easily opened, and it really reduced the time for the code to be complete from 3 minutes to a minute and a half. So a big difference. Reminders and checklists. This is a WHO surgical safety checklist. Okay? These are important, but now you really have to start thinking about humans really have to do this, right? So you have to have the diligence and attention of the human to actually do this. Rules and policies, they need to be done, but sometimes, as this shows, they're not really effective. And education and information. So again, the hierarchy of effectiveness. From most effective are these things like the forcing functions. Less effective, maybe least is a bit strong of a word, but less effective are education and things like that. And again, but the most feasible ones are at the bottom. So it's easy to change a few lines of text in a policy, but it doesn't necessarily have that long-lasting effect that you need. So we aim for high leverage interventions. So when we analyze a case or make recommendations, we aim for as high as we can. We don't often get there. It's not often that we find this really nice forcing function or this really nice constraint. But it's important to know that a single high leverage intervention can be more effective than a whole suite of lower level recommendations. Okay? So one single good recommendation can be much better than that. So you could have all the campaigns in the world about applying your brake pedal before you put it in gear. You can have stickers on the windshield. You can have all these rules and policies. But it's not going to be as effective as if you design this constraint into the system where I have to press down the gas pedal, or sorry, not gas pedal, brake pedal before I put it in gear. But in reality, as I talked about a bit, you still need to function in reality. So not all interventions can be high leverage, okay? They're least feasible, but if you can find one, that's terrific. And you need to consider the end user. So you need to do this like, almost a co-design with the people who are actually going to be affected by the policy or the new procedure or the new forcing function to ensure that they buy in. And you need to influence not work as you see it sitting in your office or on your recommendation chair. You need to influence work as actually done, how people actually do the work. And you do need, even though you might have this wonderful high leverage policy, you still do need your high leverage forcing function for some recommendation that you have. You still need education, policies, rules. You still need to tell people about it. You still need to modify whatever documentation you need to do, because that really helps the buy-in, so people understand what we're doing it for. And you need to evaluate what you have done. And this is something we're working towards at ISMP Canada, but we don't do, remarkably well yet. So when you put into action a policy or a procedure or something new, you need to really sit back and evaluate it, soon after and again on an ongoing basis. Is it really safer? Is this idea that we had that we thought was brilliant, is it really, working? Is it making safer? Are there unintended consequences? So a few years ago, we did one, again, on hydromorphone, where we removed a lot of the high concentration product from ward stock. And we thought this was good because people aren't going to make mistakes with the high concentration ward stock. But what we didn't anticipate was that nurses would carry a couple syringes of the high concentration ward stock in their pockets because they anticipated need. And it wasn't because they're bad people or any sense of malfeasance. It was just this sort of efficiency because they knew we were going to need it and they didn't want to go all the way back down to the pharmacy while their patient was in pain, come all the way back up and then draw it up. So they kept a couple doses and we continued to have errors. So that's one of those unintended consequences you have to worry about. So how does this work in real life? So we'll go back to our 9-month-old baby case with ear infection given 4 milligrams of hydromorphone. It's supposed to be for an adult patient. Thankfully, someone caught it, treated them appropriately, and everybody went home well. So when you sort of get all the information you can out of a case, this is what we found, or these were our findings on investigation. The order was written on the wrong chart, okay? Probably because the patients had similar last names, but also because it's the emergency department, all the charts were on one single section of the counter, and the physician or the nurses just went chart to chart to chart. When the nurse requested confirmation of the order from the doctor, so the nurse really thought, well, this doesn't sound right. Neither use patient identifiers, so this doesn't sound right. Are you sure this is what you want, 4 milligrams hydromorphone? And the doctor said, oh yeah. So neither one fully understood who the other one was talking about. At this time, 15 years ago or so, there was a lack of familiarity. People were still using a lot of morphine. A lack of familiarity and understanding about how strong hydromorphone is because they weren't using it very often. They'd only used it once in the previous 2 months. So it wasn't a drug in high use. And despite that, they still had it stocked in regular stock in the emergency department. So it was there to make a mistake with. So if you think about things like forcing functions and automation and standardization and all the way down to education, what actions would be most likely to prevent recurrence? And I'll give you sort of a selection of things here. And if you can, does anybody see a forcing function there? Okay, yeah, E could be a forcing function. So there's store medication separately, sort of pediatric meds separately from adult meds. Include information about it in communication books, things like education and requiring double checks and remove hydromorphone from stock. If you sort of plot this on one of our hierarchy of effectiveness graphs, you can see that, the forcing function in this case would be remove hydromorphone from stock in the emergency department, which worked back then because people weren't using it anyway. It would not work now because people are using it. So it would be a non-feasible approach. It would still be effective, but it wouldn't be as feasible. So storing pediatric medications separately from adult medications would be, a bit of standardization or simplification. Requiring independent double checks is sort of a type of reminder or double check. It's also a rule and policy. It still requires people, but it might have caught this error. And certainly, you do have to educate people about it, about the dosage, about what's an appropriate pediatric dose, because that might have triggered something as well. So human factors in medication safety, understand that humans will make mistakes. Nothing I say here excludes the exceedingly rare or excuses the exceedingly rare occurrence where people willfully cause harm. okay? But most people, as you know, the original principle, almost everybody, almost all the time, goes to work not intending to harm people. The keys things are figuring out why the mistake happened and think about how humans can be tricked up by various things. And do your best to design the high leverage mitigating strategies. So those high leverage, get up in the hierarchy of effectiveness as high as you can. And also, you know, evaluate. Make sure you continue to keep an eye on things as you change things. Because sometimes you do have unintended consequences. And something we don't do well in healthcare at all, no matter where you are, is share. If you have a really good idea, if you've implemented an excellent process, if you've had an incident that, you know, you're worried other people might have the same thing, make sure and share it. Set up systems where you can share these ideas and share this, because someone else down the road might have gone through the same thing and have a slightly different way of approaching it, and you two can work together. Thank you.